This conference will now be recorded.
Okay, so I'm going to start again with a reminder that we have a survey going, and we'd really appreciate at some point if you would go and copy the address for the survey that's up in the chat box in the upper right and fill that out. It will be helpful for us. AnCan's grateful to the following sponsors for making the recordings possible. They include Bayer, Foundation Medicine, Janssen, Myriad Genetics, Novartis, Telix, Blue Earth Diagnostics, and all the other donors who come to these groups who choose to support the activity. And let's see here. AnCan respectfully notes that it does not accept sponsored promotion. Any drugs, protocols, devices recommended in our discussions are based on anecdotal peer experience or clinical evidence. We cannot and do not provide direct medical advice. We encourage you to discuss anything you hear in these sessions with your own medical team before making a decision. So thank you so much. And we can get started here. Can we hear from Paul? I'd like to go through. Paul, how old are you?
I am just turned 72. Yippee.
And yeah, and Atlanta, I'll put you down as Atlanta because that's what most people will know.
Ridiculous. This is ridiculous.
What?
That's what.
Rick? I'm sorry about that. When were you first diagnosed and how were you diagnosed?
My PSA started going up, and they referred me for the MRI. Time frame is I had my first MRI was April of last year, 2023, and then my PSA went up again before I could get a biopsy, and then my biopsy I had, and it confirmed that I had um, 3+4 involving 16%. And I'll be honest with you, I have to read a lot of this because I have not been on very many support groups.
Okay.
And I'm here one
Do
time.
you know how many biopsy cores they had and how many were positive?
They had Gleason pattern 4 comprised of 10%. 4 or 5 cores contained cancer.
4 of 5, did you say?
Yeah. Yes.
Okay. And was it a transrectal or transperineal biopsy? Do you know? Was it?
Transrectal.
Okay.
And the guy did a good job, thankfully.
Yeah, that's fantastic. And
Yeah.
the pathology, where do you know where that was done? And have you gotten a second opinion on the pathology report?
I sent it to John Hopkins
Great.
and came back that they agreed. Seemed to
Okay.
be in line. And
Um,
I'm at the point where, and the reason my PSA, my last PSA was in August 14th. It was 5.64, and then with less than 3 months, it went up to 9.2. That's what right now is concerning. And
so what have you heard from different physicians about how you might proceed?
well, the first thing I did was we got an MRI. I just had one Friday, and I haven't gotten results. And
What?
that's kind of where I'm at. We're going to do another PSA test at the end of September, just to see if that first one might have been a fluke. So we're going to redo it in about a
Okay.
month.
So what was the reason for repeating the MRI? Just that it's a year.
Yeah, it's over a year.
Yeah.
Yeah, it's almost a year and a half. Or
Okay. And so are they pushing you in any treatment directions based on this, or is it really just waiting for the biopsy
yeah,
or waiting for
I'm
the MRI
pushing.
result?
I feel like I'm pushing myself into a direction of treatment. I don't think I'm cut out for the active surveillance. To be honest with you, it's just I'm at the point where my wife just recently passed away, and I just recently started to try going out and start a new life and so forth. And then I got the cancer handed to me, and it's like I don't want to bring that on to a new relationship or anything. So my life is like on hold, and I'd like to kind of just put it behind me and do the best I can, and you know, be able to live some sort of a normal life.
Well, no matter what you choose, there's still, a possibility of this coming back and a possibility of having some side effects. But I think we had talked earlier about radiation therapy and SBRT, and some of the different systems that are out there. In Atlanta, there is an MRI LINAC set up at Northside Hospital, and we had mentioned looking at that. And you're set up to see Dr. Johnstone in Tampa as
Mhm.
well. Do you have any questions for the group in terms of how you might proceed?
Yeah, I mean, I think it's a smart choice with the SMRT. I hear a lot of Tulsa Pro, and that's going to be probably the first of the year where Medicare is going to insure it, and focal treatment. There's all those that come to mind that seem to be very, low side effects
So
and
I'm
quick.
going to differ with you on focal, because 5 sessions of SBRT takes a few minutes each treatment. You have no anesthetic risk. You're not at a 45-degree angle with your head down for a couple of hours. You don't have to wear a catheter for 2 weeks. And there's no evidence that focal does any better than active surveillance, other than how you feel. But if you look at the PROTECT study, the data from that says that active surveillance and surgery and radiation are equally effective. Um, the studies looking at focal treatment, they say that focal is very effective if there's limited disease in delaying definitive treatment, but it does not delay radiographic progression of the tumor, and it doesn't improve survival at all. Um, my only problems with going through all this were infection in the epididymis after Tulsa Pro, and urinary tract infections. So I don't know. I'm not a big fan in a situation where there is four present. I think you're just kicking things down the road. The nice thing is that if you were to do definitive treatment now, and it's a 3-4 with 10% or 16%, then the likelihood that you would need ADT, or ADT would be advised, is going to be lower.
Exactly, and that's one of the reasons too that I wanted to kind of move. I'd rather avoid that if at all possible. ADT.
Okay, we have a couple of other moderators in the group. So, James, do you have any comments to throw on board?
Not too much, really. I mean, I think getting the second MRI is a good idea. I think when you ultimately get a treatment recommendation, I think it would be prudent to get a second opinion on that as well. No, nobody can really tell you what's right for you. I certainly understand your desire to move forward with treatment. From my personal experience, I'm glad you're not talking about surgery
No.
because I really think that radiation is probably a better option these days. Particularly if you're 70 or older, surgery comes with its own set of stresses, just in the procedure itself. But do make this decision very carefully, and you've got really time to sort it out. Don't rush yourself into a decision. Um, get a
Everybody's
recommendation
yeah.
and then
Everybody says
check
time.
it out.
I know. Time is ticking.
Yeah.
I mean, I just feel it. It's been since April of last year, so it's like, how much
Mhm.
time and
Yeah.
how many biopsies, that sort of thing.
So one thing I might suggest before doing another biopsy, look at a test like EpiSwitch PSE.
Hmm.
That test, or one called, well, that one is probably the most sensitive, and it's covered. And that might help you decide if that comes back that there's a very low risk. I'd buy what you have and not go through another biopsy. Certainly, transrectal biopsies come with greater risk of infection. And I think that more and more physicians are moving towards the transperineal biopsy. Now, that does require sedation, because there's a little bit more involved. But I don't know that I would go through another transrectal biopsy. I'd like to find someone who would do a screening test, some sort of biomarker first, and then if need be, go ahead and do the biopsy transperineal.
Yeah, I've been trying to locate somebody that does that transperineal in the area, and
And
I haven't.
I did some looking for you, and I didn't see anybody in Atlanta, unfortunately, but it involves calling around. I think you said someone else in the group did. There's someone in the advanced group that will do that. It's advanced urology, is Dr. Patel, correct? Is that his group? Paul, is Dr. Patel in advanced urology practice?
Oh,
And
I don't know. I'm not dealing with that Patel. I have a different
oh,
Patel. My urologist is Patel.
right,
You're
right.
talking.
That's the one I'm talking about. There may be someone in his group who does it.
Okay, I'll check.
Um, yeah.
Mark, Eric lives in Atlanta, and he definitely got a transperineal, but I don't know where he went for it, or if he did it within.
Okay.
Maybe you can drop him a line, and he's not on. He's not on tonight, is he?
No.
Is he?
I went
Um,
through the equipment company that sells the. I can't remember what it's called, perennial, something like
Hmm.
that. The company that actually sells the equipment, and Emory is on the list for having the equipment. So I don't know if they do it,
yeah,
perform it, but
that's probably where he went then. But we have a gent who's done perineal. I'm pretty certain he's done perineal. He has 11 out of 12 cause positive, but all 3+3. So he's still doing active surveillance. And I think he's done some research. And Mark knows him, and we'll try and find out. The one thing I think you should know, Paul, and I don't know if you do, is that the failure rate for any type of focal therapy is around 50%. And it's probably even higher if you got a 4 in your number.
hmm.
So, you know, focal sounds great. One of my very closest buddies sent me a video yesterday. I didn't even look at it, and I happened to call him up to talk about something. Oh, did you see the video? Oh, no, what's the video? Oh, it's this great 3D MRI technique and this treatment where It isn't that injurious, and I open it up and it's Tulsa Pro. And the problem, and yeah, it's a TikTok 45-second or a minute TikTok video. And the idea is to catch folks who think they can get away scot-free with treating their prostate cancer. And the problem with focal therapy is that it really only fits a very few number of people. And we see a very high failure rate. And then it compromises you when you have to treat a second time. So we're not big fans of focal. We're not saying it shouldn't be used, but we don't
Is
think it.
cryotherapy the same thing? Is that the same thing?
Yes. So,
Okay.
when you're talking cryo, you're talking HIFU, you're talking Tulsa Pro, you're talking some of the, even some of the CyberKnife types of treatments where they don't want to treat the whole of the prostate.
CyberKnife, I hear that's the same as SBRT, no?
Well, it is, but there are some practitioners that don't treat the whole of the prostate. CyberKnife is great if they're doing SBRT and treating the whole of the prostate. But our concern is when they choose not to treat the whole of the prostate, because it puts you in a very vulnerable situation moving forward, especially if you've got a 4 in your number.
Yeah, I didn't even talk about the 6 plus or 3 plus 3 I have also, but yeah, I would probably need more than one. I would need the whole treatment.
Paul, did you put your email details either signed up on the website or in the chat window? We can send you reminders for future meetings, and you get stuck and listen to or go through our email.
Yeah, I'm on the email site. I get that, but if I put on the send message, I put my email address or what?
No, that's fine. If you've gone it on our website,
Okay.
that's
yeah.
No, if you're getting reminders already, you're good. We don't. That's the only reason. We just want to make sure you get the reminders. Dr. John, come on in.
This isn't necessarily about Paul, but it put another question in my mind. I'm advising a guy that has a positive MRI in the transitional zone of the prostate, and he is afraid to get a perineal biopsy, wants to get a traditional truss. And I would like to know if anybody knows whether transitional zone, which is kind of hard to reach, is in itself more of an indication for a perineal biopsy than for a transrectal biopsy. Anybody know about that?
That's what I have read, that those areas we get better pickup with the transperineal biopsies for transitional.
Okay, thanks.
Let's see. I guess we've got everybody who had their hand up for now. Let's move on to, does anybody else have any comments before we move on? Paul, do you have any more questions for the group?
Just if anybody has any suggestions for contacts in the South, either being Texas, anywhere down here for good treatment for the SBRT, that's what I'm looking for. If I can find it somewhere within reason locally.
My transperineal was without sedation.
I'm sorry.
My transperineal biopsy was at Weill Cornell, and he refused to give me sedation.
Yeah, well, as I said, I'm sorry about that.
It wasn't that bad, though.
I can second that. I've had 2 transperineal biopsies without sedation. However, they cleaned me up off the floor after the first one because I vasovagaled.
I'm sorry to hear that too. That's obviously not fun. And I mean, I guess if it's an office setting, that may be why they're doing that. But I had transperineal was not done widely or much at all back then, and I was lucky to get sedation. Maybe it was the MD initials after my name that made that available to me. But boy, I'd sure want to think about that if I was doing transperineal biopsy, more so than the transrectal in terms of discomfort with the procedure. Okay, Lewis, welcome. Thanks for coming in. Wondered
Thank you.
How you heard about AnCan.
I think I heard it from you. I first heard about the site, and I did a post a couple of days ago, and you responded and invited me to
On
join the meeting. I'm
Inspire or
sorry.
Facebook? Inspire or Facebook?
I'm a technological ignoramus, and even
Okay.
more of an ignoramus with respect to a lot of the medical terms that people are apparently more familiar with than I am. But I saw the chats going on. I came across the chat room, and or somebody had recommended the site, and I went into it and I made a posting, and brought me to this meeting, and some interesting comments being made, which somewhat illuminating and giving me pause for a lot of think beyond the consternation that I already have.
Well, we are glad you're here, and hopefully we can help lower your stress level and bring you to the point where been there, done that is what you think about it, and that's the only thing that you get to think about this. I would like to ask you some other questions here so we can get an idea
Sure.
and see how we might help. How old are you now?
I'm going to be 75 in a couple of weeks.
Okay, and where do you live?
I live in New Jersey, formerly in New York.
Okay, and when were you first diagnosed?
Well, I was diagnosed November, the biopsy was done on November 15th, and I got the report on November 18th.
Okay, and what got you to needing the biopsy? How did they?
Well, what happened was my cardiologist had noted that my PSA level had risen from, I think it was 2.7 to 3.3 or 3.2. Recommended that I see the urologist. I saw the urologist. Recommended having the MRI. The MRI results came down, freaked me out. But the doctor recommended the biopsy. The biopsy was done, and the biopsy freaked me out even more.
And what did that show?
Well, basically there were three areas. One area of concern, which had was in Gleason, grade group 2 with a Gleason score of 3+4. One other area was a 6, and the third area, there was a small focus of an atypical gland. That's all it said. So
And how
my
many biopsy cores did they do altogether?
they did 13. I think 13 was the full count.
And do you know in the second one that you talked about, or the first one that was a 3+4, does it say what percent is 4?
It says, this is the way it reads, adenocarcinoma of the prostate, prognostic grade group 2, Gleason score 3+4 = 7, involving 40% and 30%, 5 millimeters and 3.5 millimeters in length of 2 of 5.
Okay.
Gleason pattern 4 comprises 5% of the tumor.
Okay.
According to my doctor, it's low level, early stage, non-aggressive. a further analysis is being done on the tissues, but I haven't gotten that
Okay.
report as of yet.
Do you know if that's a decipher test that they're doing on the tissue?
I'm not sure what the name of it is. Let me see if I wrote it down. All I wrote down was it was an advanced analysis of the tissue.
Okay, probably the decipher test, and that's one I'd ask about if it wasn't run. There are a number of different ones that they use to look at the tissue and evaluate where things are. You are lucky in New Jersey in that one of the tests that's available is called Artera, Artera. And that test uses artificial intelligence. It reviews the slides and provides guidance as to the likelihood that you would be a good candidate for active surveillance. From
That's
what you
that's testing
have,
in New Jersey. I'm actually being treated in New York.
doesn't matter, it's where you live.
Okay.
So unfortunately, that test is not available in California or in New York, but it's based on where you live and not your doctor's office. So you should be able to do the Artera AI and get a good idea as to the advisability of active surveillance. The other thing that's important is we find that we're getting better readings at facilities and hospitals that just focus, or departments that just focus on reading prostate biopsies. And that is in New York. One of the people is Dr. Ming Zhou, Zhou at Mount Sinai Pathology. And then the other is Johns Hopkins. Those two centers read more prostate biopsies than anyone. And I certainly would have the slides looked at by them and see if they concur on the reading you got locally, unless the biopsy report is from one of those two.
No, my treatment, most of my treatments are with doctors affiliated with Lenox Hill Hospital and
Okay.
Northwell Health. And
So you do want to send the path out for a second opinion on the path, and then potentially look at the Artera. I think those would be things that you would do. I'm going to ask Dr. John to comment because you mentioned about the freak out stage, and one of the hard things is getting a diagnosis of cancer and then told, yeah, but it's not really significant, and you may want to just watch it and monitor the situation. And living with that kind of decision can be hard. So, John,
yeah,
what comments might you have for Lewis?
Well, Lewis, you kind of brought me back to when I got my biopsy results. I hate to think about how nervous and anxious and shaky I was. I thought I was cold because I was actually shaking. I had trouble sleeping at night. My doc
and
gave me some.
I still am having trouble sleeping.
Yeah, I got some help with a sleeping pill and something to take the edge off my
Yeah.
anxiety for the first little while till I got used to it. Yeah, we get that terrible news and it completely turns our world upside down. The confusion about whether it's a serious illness or not a serious illness that Dr. Mark raised is because prostate cancer does tend to be fairly slow moving. It does give us a little bit of time to make decisions. We don't usually have to make them under too much pressure. So yours, as you know, is not the very most benign and it's not the most malignant. You're somewhere in between, kind of on the low side of in between. So I sympathize. If you want to come to the men's group and talk about it, you'll have a lot of sympathetic ears. We've all gone through that first month or two. Um, get help if you need to. Talk to us some more. Somehow, a feeling of somehow the shock and denial wears off after a little while, and we start to accept our new situation with a little more calmness and sometimes even serenity. So I I encourage you to just tough it out for a little while, other than maybe get some medicine to help you sleep.
I have both. I have one in hand and one in the works. Some of the questions that from the discussions that have been had, um, I tossed back and forth about getting second opinions, was coming to the conclusion that a second opinion wouldn't do any better than what my doctor had recommended as a procedure based upon the findings. I guess I had the perineal biopsy rather than the other one.
Well, we don't
Um,
think you need a second biopsy, but
a
it's
second
really a
review.
very it's a very subjective art to read slides, and so we do like to see a second opinion by an expert to make sure you really are, in fact, a 3+4, because everything is based on that, as well as your PSA movement and your MRI, and maybe you're going to have a decipher test to help guide your treatment decisions in the future. We don't know.
Well, no, the test, the decipher test has been ordered. I probably should get it within the next week or so.
Okay. Well, if you
Um,
come back, we'll really be interested in hearing about that.
I mean, I have a follow-up appointment with my doctor January 6th. Um, he has recommended focal therapy as the treatment, and until hearing the comments that were made a short while ago, um,
We're not crazy about it because I suppose there's some people that get cured and then we just never hear from them again, so it biases our opinion. But we 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 see people relapse. The research suggests that people recur,
well,
and
that was sort of the doctor's recommendation wasn't with a guarantee by any
no.
stretch of the imagination. Basically, his attitude was it's less invasive, less side effects than radiation. I mean, one of my
Yes.
comments to him is you watch TV and every other commercial comes in talks about how this center is better cancer care than the other center. I was getting, how great CyberKnife is, and I've heard horror stories about CyberKnife or the other similar techniques that there are. Um, I was given the names of three doctors at Sloan Kettering, and there's a Sloan Kettering annex near my house, but that's basically a place for radiology that I was considering. Um, I mean, my inclination has been to follow my doctor's recommendation. Um,
So, Lewis, I would strongly suggest getting that second opinion on the path and doing the Artera. When you're talking about focal, that's usually done by the same urologist who will be doing the surgery, who often has a vested interest in that. Um, there are some good people at MSK, and you'd want to see a radiation therapist before just running off and doing what a urologist recommends. Um, but
Mhm.
there really is a lot of controversy now at 75 of even screening and doing anything at all. And I'm not sure I agree with that. I'm um, some places are saying they don't want to pay for PSAs, and I think in UK they don't pay for PSAs over age 70 because there's no intervention that makes a difference. If you were 60, looking at it and being more aggressive with treatment might make more sense than at 75. If you're planning to live to 100, then what you want to do is invest in getting the best information before a decision. And Lenox Hill is not a center of excellence. Lenox Hill MSK in New Jersey is not MSK Center of Excellence in prostate cancer. So I think you want to get people who only do prostate cancer, but have the whole realm of treatments to offer if in fact you need treatment. I'd also recommend, we're sending you all over the place, but I'd recommend looking at the active surveillance group. And I don't know, Rick, offhand, which Wednesday that meets, but that's on a Wednesday evening, and that might be a very good opportunity for you to hear a different side of it. But I don't see, my experience is that focal can cause risks as well. What it's short on is benefits.
Yeah. Well, why don't we bring in Jim Schreit, who's also a moderator for active surveillance, and that group meets every Wednesday, the first 4 Wednesdays of the month. So there'll be a meeting on Wednesday. But Jim, you want to talk to Lewis a little bit about, from what I heard, he didn't have very much and he might be a great candidate for active surveillance. Now, I will just say this. Your urologist probably isn't going to tell you that, Lewis, because he ain't going to earn too much off of you. But go ahead, Jim.
Well, I think a couple of things. I think one of the values of a second opinion is that every provider, and in fact, most institutions, have some biases about what they promote in terms of treatment. And, you want to have more than one view of that. I think in terms of active surveillance, yes, by all means, come to our group on Wednesday. What I wrote down from what you said was that out of 4 cores, that there was only 5% of, I'm sorry, there was only 5% for in the one area with 3+4. We have guys that are pursuing active surveillance with that kind of profile. And so I think it would benefit you to talk to them, hear their stories, hear what their rationale is for doing that. I think, especially at your age, I don't know whether you want to rush into treatment at this point, because treatment, whether it's focal, whether it's radiation, whatever it is, surgery, God forbid, is going to have side effects. It's going to change your life. Active surveillance comes with, I think, a certain amount of anxiety surrounding repeat PSA tests and MRIs and so forth. But there are ways to cope with that. And I think also in terms of your current anxiety, if you can talk to some guys that are in a similar place and are managing it with active surveillance, I think you'll find some comfort and hopefully some calming advice, because where you are right now, just diagnosed last month, this is really one of the hardest places to be in this entire process. And we've got a couple other hands up, so I'll shut up, Mark, and let you call on somebody else.
Okay. Stuart, you had your hand up first and then you took it down. Did you want to comment?
Yeah, Lewis, I started through a very similar journey to you back in April, starting with my personal urologist who said, "Oh, you're a great candidate for focal." And oh, by the way, I do focal. And the hardest part of that conversation was getting him to tell me how many focal therapy treatments he had actually done. It turned out you could count them on both hands without going to your toes. Uh, and I started investigating focal, and I went to New York. I'm in Connecticut, so I went into Manhattan and started going to the centers of excellence. And if I was going to do focal, I'd want to find the guys who have done lots of them. And I've talked to a doctor at NYU who has done hundreds of them. And, there's a guy at MSK who's done in New York who's done hundreds of them. That's the person I'd be talking to get information if you wanted to pursue that. I did that, and the more I investigated focal, the more I started to realize that the percentage of recurrence was higher than I was comfortable with, and so I actually ended up. I'm in a clinical trial that's a combination of focal and SBRT. So I've got a combination of coverage because
What's
doing
the
focal, but
what's the SBRT? I mean, I've heard that.
that's the radiation.
Okay.
And my radiation was done at MSK on the MRI LINAC machine. Uh, but the more I heard about focal by itself, I wasn't comfortable with, a 1 in 2 chance of having the recurrence, because the last thing I would want to do is have to do this treatment a second time.
No, again, the doctor's comment, and seemingly this doctor is very well credentialed. I vetted through the remarks on available websites. And seems knowledgeable. He also has expertise in radiology. In fact, he picked up on something that wasn't disclosed in the MRI when he did the prostate examination. It's a
The
lot
other
to
thing
think. It's a lot to think about.
the other thing I'll tell you, because I had a focal treatment in September, and it's not as simple a walk in the park as they might like you to believe. I had a catheter for 5 days,
Yeah.
and and an extended recovery, and it does, it's not simple. It's not necessarily a simple recovery.
Oh, I
So,
know the idea of the catheter scares the hell out of me too.
uh,
But a lot of
so
people that I've been talking with says that between focal therapy and radiation, focal therapy as an initial treatment is probably a wiser idea than the side effects of therapy, radiation, whether it be the cyberknife type of radiation or the more conventional.
I tend to disagree with that, and I don't think the evidence supports that. Um, Again, it depends on whether you're treating just a small spot or treating the whole gland. If you treat just a small spot, you have 60% or more recurrence. You still have bladder infection. You're put to sleep for anesthesia. You
Yeah.
can have complications from that. You don't have that with radiation. And the newer places, seeing a physician who does just the radiation, someone like Dr. Nagar at MSK, you're going to have far less issues there than you would doing the focal in Jersey. I wanted to just go over SBRT is basically radiation delivered over 5 days. It's stereotactic. body radiation therapy, and it's a higher dose per day, but the machines are more precise. The latest machine at MSK can adjust with daily changes in the size or shape of the prostate, and things move while the beam is on. That machine checks 8 times a second, and if necessary, things move, will turn the beam off to protect you. So I think who's ever giving you the information that focal is good first really hasn't spent the last 4 years studying this or knowledgeable in doing this. I think it may be the case if you're looking at going to a community facility and community physicians who treat breast in the morning and prostate and then lung cancer and then brain cancer, you're not going to get the same care as you would with someone who focuses just on prostate at a center of excellence. Caesar, you've had your hand up for a long time. Why don't you go ahead? You got your
Thank you very,
yeah, there
thank
you
you
go.
very much, Mark, and everybody. Good evening. It's a pleasure to make all your acquaintances. My name is Caesar. I'm relatively new to AnCan. I'm not still completely familiar how the system works. So I put my hand up, not so much at all to comment about Lewis and the current discussion, but just to make sure I had an opportunity to speak before the end of the meeting. I have been in 2 other meetings, first time here, but I've known that anything over 20 people, there's a chance you might not be able to speak before the meeting's up.
I was
So,
going to ask you. I was going to ask you whether you needed some time, and there are a few people on the list before you,
oh,
and
okay.
we will
Well,
get
yes,
to you.
I'd like some time.
Okay,
Okay,
fantastic.
and I'll do that.
Govinda, did you want to
No,
make a
forget me,
comment?
Mark. Thank you.
Govinda, did you want to make a comment?
Yeah, we can't hear you, Govinda. Your microphone is open, but it's not picking up. So you may need to check your mic and choose a different microphone or something similar. I just, Lewis, I'm listening to what you're saying, and I have some real concerns. We've been in this game a long time. I have personally. And everybody comes in here and says they've got great doctors with great credentials. Um, we hear it every time. The problem is that when you don't have the knowledge, you often think you may have a great doctor with great credentials, but what you're not really aware of is the conflicts of interest that exist in this business. And the conflicts of interest are significant and frustrating. So there are conflicts both with the community doctors, and there are conflicts in academic centers too, but they're different types of conflicts. Probably the worst conflict and the most rampant conflict is doctors wanting to treat you when you don't really need treatment. And that might be because they're surgeons and they want to cut when you don't need cutting. It might be from practitioners of focal therapy who want to use their focal equipment that's cost them so much money and use it on you when it just isn't appropriate. And we see that a lot. Or it may be radiation oncologists who have equipment that they've got to pay for and it's not the most up to date, and I'm not going to tell you that it's not the most up to date. And we see all of this all the time. And so if we can get people into this group, we give you a wider, better view. First thing, I think, as Dr. Mark has said to you, the first thing we'd say to you is get your ass out of out of Lenox Hill. Get yourself to a center of excellence. And when it comes to MSKCC, you're far better on Second Avenue than you are going to one of the places in Monmouth Hills, or I forget wherever else they are in New Jersey, or going up to White Plains. The reason for that is because I think we're picking up feedback from you, Jose. The reason for that is because the better doctors 90% of the time are in the city. And it's very, very hard to switch when you find out that there's a better doctor at MSKCC and they're not in one of the satellite facilities. So you're better off going there from the beginning for the sake of having to use the bridge or tunnel to get into the city. And that's been our experience. We've seen that just too many times. You have a really, really solid situation. If somebody's going to get prostate cancer, the type of prostate cancer that you have is very manageable. And it's very, very likely that you could be a good candidate for active surveillance for a long time. Now, you've got to have the mindset to be able to handle the active surveillance. We get it. That's why we have a weekly group for men on active surveillance. It's exactly why we have a weekly group for men on active surveillance. But we can support you in that active surveillance. If you've got too much for, we're going to be the first people to say to you, no, you need to get treated. But if we don't have a lot of for and we can support you and you can get by, it is a really great option. And that's why we see more and more men every month choosing active surveillance. So that's my 2 cents. I'll pass it over to Govinda.
I'll just respond to the comment. With my mindset right now, active surveillance, to live with the concept is difficult enough. To live with it as a constant is even more difficult. But I'll keep an open mind about it.
Okay, let's go on. Michael Williams, you're up. Keep us informed, Lewis, of how things go and what you decide. And if you learn anything different on the second opinion on the path, up to 30% of people will get changes that may affect what they ultimately decide to do after a review of the path by people who do this kind of thing more regularly. Michael, so I'd like to review some of the basic questions we have here and get the information, and we'll open it up to the group if that's
Sure.
okay with you. How old are you, Neil?
70.
Okay, where do you live?
Bozeman, Montana.
Okay, hope it's not too cold there now.
It's not. It's not bad.
Great. And what got you to have a diagnosis, and when were you diagnosed?
So I was originally diagnosed January of 20 with Gleason 6, and I had been under active surveillance and I had a repeat biopsy, my third one, in July 31st this year, and came back with the 6 on the targeted biopsy, but then I had another core that came back Gleason 4, 5%. 7 millimeters was the length of the core. I did get a second reading on it because I wound up moving my care to Mayo Clinic in Phoenix, and they almost completely agreed. They did say I had some high-grade pin that wasn't noticed on the first biopsy report, and they actually shortened the length to only 6 millimeter on the core of concern. I had 14 needle cores done at that particular biopsy.
And where was the biopsy read?
So I was seeing Huntsman Cancer Center in Salt Lake City, and it was first read there. And I was very unhappy with the doctor and even the mid-level, and their response to this pushed me very hard to immediately have a radical prostatectomy. So the second opinion was at Mayo Clinic in Phoenix, Arizona.
But that was with the doctor, not a pathology department. So one of the first steps might be.
Well, they did do a reread at Mayo. They got my slides. That was the first thing the doctor said to do.
But again, we would suggest looking at Dr. Ming Zhao at Mount Sinai, New York for that. And the Johns Hopkins programs, they are known for their prostate, where people are sitting there reading prostates all day, and trained by Jonathan Epstein, who, while he isn't practicing right now, is known for expertise in prostate biopsy. That's not prostate pathology at Mayo, is not one of the things they're particularly known for. Are you hearing that they might want to be more aggressive? And have you done anything like Decipher or Artera to evaluate wisdom and thoughts on continuing active surveillance or moving on?
So I did Prolaris. I got the Prolaris done just based on my own research. And again, that's one of the places where I was so unhappy with Huntsman. My doctor there told me he didn't believe in any of the genomic tests and didn't think they were very good, and just said, "Which one do you want? And I'll order it." He didn't offer me any input. And it gave me a score that active surveillance was a viable option. I believe it was 2.9 on the scale, and 3.2 is the cutoff.
Okay. The two most accurate tests right now, one is a blood test called EpiSwitch PSE, EPI Switch PSE. And that, while it doesn't have as much data as some of the other tests, it is useful at determining whether a future biopsy would be needed at some other point. So that's something you would want to do before that. Decipher is a test looking at the pathology on the biopsy that may be more accurate than the Prolaris. And then the other would be Artera, which uses artificial intelligence to come up with a score and advise you on whether active surveillance continues to make sense. But certainly from the information that you present, that would seem like an appropriate step. And James, James, do you want to comment?
You know, my comments are probably the same as before. Please come and see us on Wednesday. You know, we'd love to talk with you, and I'd love to have you talk with some of the guys who have very similar, you know, situations. It doesn't sound like you have a lot of four. I'd be curious as to what they're telling you at Mayo. Are you getting a different recommendation, or are they still trying to investigate your situation?
So Mayo, I have seen two urologists there. I'm going to get in trouble with the whole group here, but I saw the first urologist who agreed to remain under active surveillance for now, but he said that I definitely had to have another biopsy in July, 1 year away, and he wanted PSAs every 3 months. I did want to talk to someone about focal therapy, so he referred me to the urologist who does focal therapy there, and I had a conversation with him, And he said at the moment he would not do focal therapy on me because it wasn't showing up in my MRI adequate to target anything.
Mhm.
And he was actually very encouraging about continuing active surveillance. Out of anybody I talked to, he was very positive about me remaining on active surveillance.
So I would certainly
And
recommend. Oh, I'm sorry. I would actually strongly recommend doing something like EpiSwitch prior to doing another biopsies. I don't know if you had transperineal or transrectal, but there is a risk of infection with the transrectal. And again, just the way urologists are pushing focal as being less risky and an easy way to take care of this. It's the same with the biopsy. There can be complications, and if you don't need the biopsy, you really don't need it. Dr. Klotz is one of the leaders in active surveillance, and he's been speaking recently how if you don't see the area of concern on MRI, it's probably not a disease that is concerning. Now, we need to get that more research on that and other people confirming that, but I think that James Group might be a better place for you.
I have went
Mark,
to the active surveillance group once. I missed it this week or last week, excuse me, because of a time change. I'm curious, and you may not know the answer to this question, but I'm so far away from the doctors I've chosen to see. The EpiSwitch PSE, could that be ordered by just my local primary care doctor and probably my
Yes.
insurance pay for it?
Yes.
Okay. Okay. Um, I have an appointment with him next week, and I may ask about that. I actually gotten him to do the genetic testing, the BRCA1 and 2, and the other tests. So he's very up to speed on what's going on with me.
That sounds great. Any other comments anybody have for Michael? James.
no, Mark, this isn't for Michael, but I've got to close a circle here. I want to circle back to Paul, and you're invited too on Wednesday. I think if you want to come and talk, I didn't mention it when you were speaking because it sounded like you were pretty opposed to active surveillance. But if you want to come and talk and listen, we'd love to have you. So
Thanks.
I just,
I'll try and
I
take you
just
up on it.
loop.
Okay.
Can I just chime in and add one more thing? I was actually just going to write to Lewis, but it's really appropriate for any man in here that has a very small amount of, really small amount of 4. That the likelihood that this cancer will kill you with a very small amount of 4 is minuscule. And if you do any research, don't listen to the doctors who are trying to sell you a treatment. Do your own research. Go to the Memorial Sloan Kettering nomogram, run that, and even though that's for surgery, look at some of the other nomograms. It just doesn't happen. It is really, really, really rare that in this day and age that a 3+4 is going to have an adverse event, and especially if you're older. Where it happens and where we've seen it happen, and we've had men with 3+3 who have moved into metastatic, is where they've gotten bad readings, pathology readings, and those readings were never really 3+3 in the first place. They may have gotten a pathology reading of 3+3 back in 1999 or 2000, and it never really was, and they didn't get a second opinion. But if you have a very, very small amount of 4, then it's still cancer, but it's kind of like having a little melanoma that you get cut out. And you don't think that's going to kill you. You don't think of it as lethal. You think, oh, I'll get it cut out, it'll be gone, I won't have a problem again. And that's really how to think about these very small amounts of 4. They're very, very manageable. Some of us in this group, I was diagnosed T3, stage 3, locally advanced, and I did a lot of treatment. I had to do treatment. Dr. John was diagnosed with metastatic disease. He had to do treatment. But a lot of us in this group, and especially in the active surveillance group, we can manage the cancer, and it's very, very safe to manage the cancer. But again, we have to convince ourselves of that.
So one of the things that I came across, Rick, in support of what you're saying there, I thought if you had a Gleason 4+3, you had Gleason 4+3, and oh my God, that was bad disease. And turns out that if you present to the doc at the initial diagnosis and have disease that's spread outside the gland, that's very different than someone who comes in with active surveillance, gets diagnosed, maybe does some treatment, maybe doesn't, but then 5-10 years later progresses. That 4+, if it's a 4+3 at one time and a 4+3 at another, the disease that presents initially is far more concerning if it's advanced disease than disease that slowly progresses over time. In fact, if you're looking at treating disease that recurs, metastatic disease that recurs, is a whole lot more beneficial and successful than someone who comes in with a lot of metastatic disease initially. So the idea that everybody who has disease in active surveillance ought to be scared of this and scared of dying, maybe 1 to 2%. And then, as Rick said, some of that 1 to 2% may be in people who are misdiagnosed initially. If we have nothing else to add here, let's move on. Sherelle. You were having some problems with sound before. You able to communicate now? I'm not sure how we get you.
Please use the chat window, or we will also put a way for you to dial in the chat window, and then you can just call in on the
I think
telephone.
Sherelle did call in before. So Sherelle is listed twice, and I think one of them is a phone, but I guess that's not working.
One of those phones is muted. Is that Sherelle?
Yeah, I'm not. I don't see how to unmute that.
They have to unmute it themselves.
Yeah, and I don't know how to unmute the phone. Do you?
They have to unmute it themselves.
Okay. We'll come back to you and try again if you can figure out how to unmute or get the audio fixed. Cesar, you're up. And what I'd like to do is go through some of our questions to get a basic idea of what's going on, and then we'll throw it to the whole group to comment. Okay. So you are how old now?
56.
And where do you live?
Truckee, California.
I'm new to California. Is it near LA or where is it?
No, Truckee is about 10 miles north of Lake Tahoe.
Oh, okay. That sounds like a nice place to be.
Yeah, it's
What got you
beautiful.
to a doc and how were you diagnosed?
Um, I first was diagnosed in 2020 and was a got my first biopsy. Let me pull my notes over so I have them in front of me here. And was first. Oh, sorry, I'm short of breath, so it's going to take me a few moments. Thanks for your patience. The first biopsy I had was in March of 2021. I was a PSA of 4.17, so barely over the baseline of you know. I was a 12 core biopsy, and the results were Gleason 6, 3 on what looks like one core. So at that point in time,
Hold
I
on a
was
minute, Rick. Do you want to mute while you're typing?
at that point in time I was uh, happy that I thought it was great news because I was planning on having a 10 to 20 year active surveillance. I had no intention of treatment. Um, and that was, that's been my goal for the last 4 years or 3 years now, almost four since then. However, at the end of October, everything changed, and now I'm 97% certain um, that I'm going to have a prostatectomy in the coming months, and I'll explain why in a
Okay, well,
moment.
let me go back. I want to fill in some more stuff.
Okay.
Did you have an MRI before your first biopsy?
No, I hadn't my first MRI afterwards.
Okay, so that is basically the same as playing pin the tail on the
Exactly.
donkey.
Yeah. Yeah,
Um,
that's why there's more to it. I've had 4
okay,
biopsies in the last 3 years. Yeah. So the next MRI was coincidentally I've had 4, and now I'm about to have a 5th urologist. The only urologist that I've met with that first one was the only one who said you need to remove your prostate right now. The same one who gave me that biopsy. He's not a surgeon, so he wasn't in that for the money. He did admit he was a very conservative uh, physician when it comes to cancer. Him personally, he thinks cancer is terrifying and would not want to live with it in his body. And so we talked about, kind of the effects of the psychology of it. For me, cancer is just a word. It doesn't mean anything. Um, you know, that's just the way I feel. Not that it's not a thing. So my MRI was in July of that month because I asked him for a second opinion, and he said, "Well, we can also do a targeted biopsy." And I asked him to see another doctor. Is there someone else I can get? Mainly because I just wanted to hear from another doctor if they recommended removal. Also, I didn't know a lot about prostate cancer at that time, of course. And so in September of 2021, a few months later, I got a targeted biopsy. My 6 cores, my PSA, and it was MRI guided. My PSA was 5.05, so I just creeped up. It could have been lower or could have been higher. It was so not much at all. And that resulted in 2 cores Gleason 6. So that doctor said, "Oh my gosh, you've got time. You don't need to do anything. You have cancer." And I said, "Good. I'm going to keep skiing, disc golfing. Life goes on." Um, in September of 2023, I had another MRI because my PSA had gone up to 9.16. So it had almost doubled. That was a 14 core biopsy, not, it was also MRI guided, but my doctor here in Truckee, since he was new to the facility, he's been a practicing urologist and surgeon for 30 years, but he retired out of surgery and is only doing, consultations and
okay.
examinations for patients. So he was well experienced. And in addition to targeting, he wanted to get more samples. So that was a 14 core biopsy, still resulting in Gleason 6. I was elated that I was going to continue on active surveillance for the rest of my life. And then in March of this year, or I'm sorry, December of 2023, my PSA had climbed to 13.46. And then I had an MRI, only showed one lesion, a T2 score of 4, 1.3 centimeter lesion. So now I'm with the VA, and so the VA has been seeing me since January of this year. I really like my urologist. He's not a great surgeon. He's admitted that to me, so he's not going to be doing my prostatectomy. But in this month, last month, November, my PSA had jumped to 24, and I had my fourth biopsy with my urologist, and it resulted in, let's see, 3 cores at Gleason 7, and one additional.
4 or 4
Oh
plus
yes,
3?
yeah. I know that's a very important distinction.
Yes.
3 plus 4s. So
Okay. And
based on what I've said so far, I'm still a candidate for active surveillance, other than the fact
well,
that now my PSA had jumped to 41.
I think
So,
I
yeah.
think there are some other steps along the way that would be helpful. Obviously, the PSA is important, and getting up in that range would put you into an unfavorable intermediate, and it might be worth at your age doing the genetics screening. And Rick is going to post in the chat window a link to the PROMISE study where you can enter your data and they send you a kit and you do a cheek swab, and it helps determine whether you have any germline genetic markers that would promote the cancer and make it more likely. The other thing I think is important is to send the tissue to either Dr. Ming Zhao at Mount Sinai or Johns Hopkins to get a better read on it. It does cost a little money, but I think at this stage with the rapid rise in PSA, it's important to really know accurately what's going on in the extent of disease. With the rapid rise and the high PSA, you may be able to convince them to do a PET scan to make sure that there is no spread outside the gland. I'm curious, obviously at this stage, you're going to want to get this treated, and I'm not sure that with a rapid rise like that, I'd consider this a good active surveillance case, also with the size of the lesion. But I'm wondering what is your thinking by surgery versus radiation?
Oh yeah, that's another important detail I left out. Thank you. In 2022, I met with an oncologist, only one, and she, after our meeting, and it was a pretty brief one actually, meeting with her, she, she knew I wasn't moving forward with any treatment, but she said she can't recommend radiation because of my age. They don't. She said that they don't really recommend radiation. Her baseline is 60 years old. And then my current urologist, who's the only other person I've really talked about age thing, I just thought 60 was an industry standard, but he said 65. And so,
Okay, so what you're getting, I know what the story that they're telling you, and you're not seeing people who are skilled and understanding in the situation, unfortunately. Yes, people who are 56 will do better at surgery than someone who is 75. People who at 75 go through the surgery have a hard time. It's not an easy surgery to go through. At no age is surgery more effective than radiation? At no age are the side effects from surgery going to be less and delayed. Radiation has side effects.
Oh,
You'll
yeah.
see about 40 to 50% at 2 years are going to have incontinence and or
Yes, I
erectile
actually prefer,
dysfunction.
I would prefer radiation if it was up to me. However,
Well,
it's not the side effects. It's the fact that the fact, 'cause I say it as fact, not that I know anything, but about 3 years ago, I read the Walsh book, kind of, I don't know if it's a bit of a prostate cancer Bible. It's kind of antiquated, I think, now.
yeah.
But even in that book, I discovered that with radiation, there's a chance that cancer can manifest in a patient 15
Yeah,
to
certainly.
25 years
Certainly.
later.
We can get, if you have one cancer, you're more likely to get another. And even if you have surgery, there is a 1.5% risk that you will be back with another cancer. Most often, it will be bladder cancer, which is eminently treatable. Um, the newer radiation has cut down the borders and the amount of normal tissue by 60%. If it's the MRI treatment, it's cutting down the amount of normal tissue radiated by 60%. Some of the people using CyberKnife also reduce those margins, and it's now thought that it's going to be less than 0.5%, maybe not at all, with MRI Linac. They don't have all that long-term data, but it's not, if it's 1.5% after surgery and 2% after radiation therapy, does that make sense to take on the risk that for the next 40 years you could be dealing with incontinence and or erectile dysfunction? I mean, that's not a nice place to be. And
Well, that's my biggest
James has
fear.
his hand up. Let's move to James and hear about surgery.
Mark, I got to weigh in on the Walsh book, and I don't know which version you're looking at, but the new version is just as terrible as the prior versions. I will tell you that I read the Walsh book. It's nothing but a promotion piece for radical prostatectomy. I read the book, and it was instrumental in my decision to have surgery at age 58, and it's the worst decision I ever made in my life. If you're relying on the Walsh book for anything, look elsewhere before you make a decision, because their little song and dance about the sexual effects or just erectile dysfunction is bullshit.
Yeah,
Orgasm is
I'm not,
you
I,
know,
I haven't, I haven't really thought about the Walsh book much. The only reason I mentioned it was just the fact that I remember reading that there is a, a chance uh, of a cancer caused by the radiation 20 years later. That's the other stuff out of the Walsh book doesn't
yeah.
really, yeah. So I'm not.
The problem with that is the radiation we were using 20 years ago, that now they're seeing those cancers, is not the radiation we use today. It's totally different.
Yeah. And yeah,
That's
so
that's
the only
that's
reason
right.
I mentioned it
And
is because two physicians, two of the oncologists 2 years ago and my current urologist, have both confirmed the
But
same thing
yeah,
about there being a higher risk of cancer caused
so
by
I
the.
think you're seeing people who are not up to date and are pushing and not experienced. And it may be an oncologist who in the morning is doing lung and breast and then do brain and prostate and colon cancer. And you don't want to see that. I'm going to ask Rick a question here. I know, Rick, you had your hand up, but I'm wondering if Dr. Reddick, at the VA here, might be a better source of information from him that's targeted to prostate cancer.
Well, I mean, I certainly, my guess is you're probably going to Reno, VA. Is that right?
Yes, but real quick, Mark, when you said the VA here, is that VA California or
Yes.
VA DC?
Yeah.
Okay, good, because I can go to any VA, and I don't know if you're thinking of Palo Alto or San Francisco.
No.
But those are options
So
for you.
let me continue a little bit. Okay. There's a number of factors. The first thing is I just added your name to get the veterans, the reminder for our veterans group. We have a veterans group. It doesn't focus on treatment. It does focus on benefits and on healthcare. So they will help you. Dr. John just left, but Dr. John was a career MD provider in the VA system. So Dr. John is really knowledgeable about the VA system. Reno is not one of
Excuse
the
me,
more.
Rick. I'm writing notes. Is that Dr. John Reddick? I think Mark
No,
mentioned.
Dr. John Antonucci, who was in the group right now. Okay.
Oh, okay.
So we're going to send you, and there are a number of people on this in this room, and they'll speak in due course. Richard and Causley, who attend the veterans group, and they'll give you some idea. I don't know what the cause of your lung issues are. They could well be service related. If they are service related, we'll talk to you about that. I will tell you that we put our moderators up against any VSO anywhere to do a better job than what you're finding. Now, when it comes to the VA in the area that you live in, which I do know very well, my view is you're best off at UCSF. At San Francisco. And the reason is because the docs who practice at UCSF double up at the VA in San Francisco. So you're going to get much better care than if you go to the VA in Martinez, or if you go to the VA in Reno, or even if you go to the VA in Sacramento, because the staff
So,
at
Rick,
UC Davis are nowhere
let me
near as
interrupt
good.
you one more time. I'm not going to be treated by the VA. I've been gone. I went to community. I asked for community care. So right
Okay.
now, my January appointment is with Urology Nevada.
Okay.
Dr.
Well, forget
Canales.
that. Forget it.
Right,
Forget
right.
it.
So what I want to talk to
If
them
you want
about
to
is
go for community care, go for community care at the VA at UCSF, because they
okay.
don't have an interest in cutting you. Nevada
Well,
urology,
that's
rubbish,
helpful information.
rubbish,
Don't yell at me.
rubbish.
Don't yell at me.
Okay.
I'm not opposed to anything you're saying.
Okay. So
So
you're
please
better off
continue.
going down, getting your butt in the car, driving down to the west side of San Francisco, going to the VA there, and getting one of the UCSF surgeons to cut you if you decide that's what you want to do. But the fact is that those surgeons are good enough to decide what is the best for you. You may finish up getting radiation, and you may get it from from an absolute world-class radiation oncologist by the name of Mac Roach, who happens to be my doc. Why? Because he does a lot of work at the VA still, and he works out of UCSF, and he's going to give you the best. Now, clearly you have lung disease. I don't know what. I don't know if it's service related, but that becomes another very big issue. Do we want to be doing surgery on somebody where they're upside down for 4.5 hours and they have lung disease? That becomes a big issue. I don't know to what extent they discuss that with you, but I'll tell you something.
a major concern.
Those docs
I
at
told Mom,
UC, those docs at VA San Francisco will be looking at that very, very carefully before they take a scalpel to your gut. Very carefully. So the best advice we can give you is number one, go to the San Francisco VA, where you will get treated by a UCSF doc. But you have to tell them when you go in, I only want to see a UCSF doc. There's plenty of them there that operate, and there's some really good ones. And number two, get your ass over to our vets group, because they're going to make sure you're getting all the benefits that you're entitled to right now.
okay, so this has been really helpful because the only reason I planned to see a urologist in Nevada was the convenience of the drive, number one, and number two, to ask him who the best person to see is, not with any intention of having him or her be my surgeon or who's going to be treating me. But this may save me a big step. What I can do tomorrow is call community care so that they can and request that I cancel my urology appointment in Nevada and get VASF, because they did say that was an option. So I'll just cut out the
Right.
extra
And make
step.
sure it's San Francisco, not Palo
Yeah.
Alto.
Yes.
Palo Alto uses Stanford docs. In our view, with the greatest respect to a lot of the Stanford docs, they are not as good on prostate cancer as the UCSF docs.
Okay, good. Well,
Across the
that's
board.
tremendously
Causley, let me come to either Causley or Richard. Is there anything that either of you guys want to say to Caesar?
Yes. I don't know where much about what's going on in his section of the world, but I had my treatment here at the VA, and they're affiliated with a local teaching hospital here, and we have the same docs going back and forth. So I thought I got the best treatment I can in my area of the world.
And my comment.
That's San Francisco, also.
No, I'm in Arkansas.
Okay.
And Cesar, I just shared my phone number with you. I had radical prostatectomy 2 years ago, so I put my phone number in the chat for you. And so I'm sharing with you that if you'd like to talk sometime, just give me a call and let's visit on another day.
Thank you. Very kind.
Go ahead, Richard.
Oh, Caesar. From personal experience, I can tell you, when Rick pounces on you, it's with good intentions.
Oh, I understand that. No, my brevity
on
and
what he
closeness
recommends, it's
is only
very valuable. So
only to allow other people time.
Yeah, make sure it's points well taken, and you'll see the outcome. He drives homes at the point.
I've been in
his own style.
I've been in.
Okay, we do have a few more people who had requested some time, so we'll move on. Cesar, if you'll check back with us and let us know what you decide and what you find out. As a surgeon, and as someone who lost a friend, a healthy young 58-year-old marathon runner friend after surgery from pulmonary embolus, it's not as easy as they always say. Surgery always has risks, and that's why I avoided the operating room as a surgeon.
Can I just say, Mark, yeah. Can I just say the next vets group is on the 17th of December. You'll get a reminder. I've signed you up, but just check off the Tuesday, the 17th at 5 o'clock East, 5 o'clock Pacific in this same room.
So we've got 3 or 4 more people on here, so we'll try to be succinct and get to everybody so that everybody has a chance. John S., you're up.
Yeah, good evening, everybody. Finally pulled the trigger went to see Dr. Nagar and started my treatment. So I finished my treatments at MSK. Thanksgiving week, I did 3 in a row. And then the following week, after 5 days, I finished up last week, Monday and Tuesday. Pretty uneventful. The machine, the Unity Electra never even gated. I never moved. My organs never moved. So I was in and out of the tube in a half an hour. And I didn't even need a full bladder. Empty bladder, empty rectum. I don't know if it's something new, but then I even questioned that with the nurse. She goes, no, the machine is that accurate. So I don't know. So, yeah, it was quick treatments, non-eventful. And that's about it. I didn't use spacer. Dr. Nagar was very confident I didn't need it. So that's my story. Side effects so far, got a little um, urinary flow right now. I mean, it's not bad. It's just a little slowed up the flow. I'm taking uh, alphonsus, and I mean everything's good. It's a little irritation, but so far it's a week since my last treatment, and that's
Sometimes a leave can help with that early
yeah.
irritation, and try it for a week.
Yeah, I've
Tweak
been.
your day.
Yeah, I have a little mark. I have a little discomfort down in my bladder area, but I mean everything's pretty good. Minimal. I mean it's only a week, so I'm hoping for the best. And you know, I had to
Well,
treat it because I had 2 cores, 3+4, but it was 35% and 20% 4,
I'm
which
glad that we finally get you to
yeah, you
come up with
pushed
a
me.
decision.
So if anything happens, I'm coming in. I'm only kidding.
That's okay. I'm listed in the phone book. You can do that. But now that you're in the boring stage, this is the most important part. And what we find after treatment, if you don't want this to recur, the best thing you can do is talk to your friends, talk to guys, and tell them to make sure that they get checked and get their PSA. And then
I
if it's elevated, do something about it.
Yeah, I already talked to 3 guys, and I spoke to my stationary engineer today in my building just quickly, and I told him, yeah, I got treated, and his best friend, 39 years old, just got diagnosed,
Yeah.
and he's devastated. So, yep,
Well,
what's
tell
going
them to
on?
come and join us here. Richard,
Yeah,
you're up next.
Okay, thank you. Yes, before I got some clinical readings here post treatment. Before I go any further, I want to make a special request from Rick. Could you, in the chat box, Rick, could you send me Dr. John, was it Antonucci's email? I need to ask him some questions pertinent to the VA with some of my clinical readings. So since he's gone, I'd appreciate it if he could send me his email if that's possible.
I'll tell it to you, but I'll also put it in the chat window because it's super easy. It's Dr.John@ancan.org.
Oh, okay.
Okay, so but I'll put it in the chat window too.
Oh, please. Okay, thank you. Okay, gentlemen, this is what I'm going to read here at first is the clinical readings from my 6-month post-treatment appointment with my oncologist, and then at the end I have a PSA question. So the reading from the doctor's notes from Johns Hopkins, my symptoms have nocturia 4 times a night, incontinence, changing with pads twice a day, and that's because of urge incontinence. And let's see, Dr. Mark, let's see if you could interpret these readings. It says here, patient reported outcomes. IPSS satisfaction 27/3. And then there's another reading. These are capital letters. SHIM, the number 4. And then I have another reading. It's epic bowel score 91.7. Then at the end, the assessment is that he says, I'm doing well without clinical evidence of progression, moderate LUTS, that's capital LUTS, with urge incontinence. Is any of those are you familiar with those terminologies?
Well, I'm not as they are scores that they use to quantify the post-treatment condition. And LUTS is basically the urgency, incontinence, frequency kind of thing, nocturia that you have. Nocturia is getting up at night to
Right,
pee.
right.
So, you know it's a questionnaire that they have you fill out so that they can keep track for research primarily. I mean, it's an effect of digitizing what you're telling them that, hey, I'm having some bladder issues. Now, remind us again about what treatment you did.
Oh, SBRT. And this
Okay,
is the
and how long?
6-month follow-up.
6 months. Did they talk to you about doing anything to improve on that? Do they have you on any medicine?
Yeah, the one that was mentioned earlier, the
Right.
alfuzosin.
Yeah.
Yeah, but those values that I read to you, of course, I'll do some further research, but I was going to use those to make a case for what they call residuals in the terminology of the VA, because long term, how these residuals are stacked, I can get either a 60%, 40%, or below. But last but not least is that 6 month follow up, my PSA was a 5.95. I may have mentioned that before. Pre-treatment, it was 11.7. The oncologist didn't seem to be too worried. He said it was going in the right direction from 11.7 to 5.95. So he didn't seem to be worried. But in terms of back during the days of active surveillance, that's certainly a number for high anxiety. And
They treated the whole gland.
you know, I I don't think so. No, it was
No, I
just
mean,
the area around that, the tumor area around the urethra. I don't know if I could see that in here. I read that part in here. I can't answer that question accurately.
that doesn't sound it doesn't sound right to me that it would be that high at 6 months. What was your Gleason score beforehand, and do they have you on ADT?
Not on ADT. Gleason score 7, 4+3 before treatment.
And did they do a PET scan before treatment?
No PET scan, just MRI.
And they're telling you everything is fine. I'm not a urologist. This is not my area of expertise, but with a level that high still, and with Gleason 4+3, a PET scan would be the modern day standard prior to any treatment. And they can't say that this is high, that it remains elevated because there's disease elsewhere. They also, normally with a 4+3, they would discuss, and hopefully they discuss with you ADT, because quite often that's done. Your post PSA was higher than mine before treatment, and I had disease outside the gland. So I think I would ask for a PET scan at this point, and I'm just wondering if you're getting the advice that's appropriate.
Well, it's from the Hopkins. The gentleman is Dr. Stephen Greco. He is head of radiology at Suburban Hospital, and he was also head of radiology at this treatment center that's about 2 miles from that hospital, suburban hospital.
Radiology or radiation
Oh, I'm
oncology?
sorry. Oh, yeah, true. Good point.
Probably radiation oncology, I would
Probably,
think.
yeah.
But it just, that's not, as someone like a radiation oncologist, before you treat someone, you want to know where the disease is. You want to know the extent of disease. And it sounds kind of like ready, shoot, aim approach. If you don't know, the Gleason 4+3 would be, I mean, back in 2020, I ended up getting a PET scan because it was 4+3. So that's something I would push for. Anybody else have any? Paul, you had comments.
Yeah, just a quick question regarding the PSA level for Richard there. I thought I read, and somebody else also informed me that with radiation, the PSA is not going to go down dramatically post-treatment immediately to like somewhere around 1 or 0. It's going to be ramping down rather slowly. So 6 months, almost half of the uh, pre-treatment PSA. I thought that would still be okay. Now I'm not 100% sure, but that's why maybe the doctor was still not showing too much concern about that PSA. It's still ramped down slowly, not like surgery. That's why I thought that was
Okay.
okay.
Yeah, thank you, Paul, for that comment. One of the reasons that I'm concerned about all these numbers is that more, in addition to whether or not the cancer is still there, is that I got a letter from the VA saying, well, this is post-treatment, 6 months, we're going to drop your benefits from 100% to 0. It's like, what? So I have to accumulate data to make a case, hey, this reading is high, I should at least continue for another 6 months to reassess it, to get some more clinical readings to see whether or not the cancer is in remission or not, or if it's low enough
Yeah,
to
yeah.
consider
I mean,
other
I think
things.
I I think your situation is very important to push for that while you still have 100% coverage, because if they're dropping you and you end up actually finding that it slows down or it doesn't drop entirely, and you do a PET scan a year from now and find out, oh, there's disease outside the gland, it means you weren't treated initially, and they're off the hook. You're still having symptoms like this. Um, Before they kick you out, it would be a good idea to get a cystoscopy if you're still having those symptoms 6 months post-op. Normally, with SBRT, by 3 months, at least with the MRI Linac, it's less than 1%. Maybe 2% are going to have significant bladder symptoms. So it doesn't sound to me that you're getting the level of care and thought with treatment. Certainly, the PET scan should have been done beforehand, and they should have talked to you about ADT.
Yeah,
Do you know
good point.
if the radiation therapist is just doing prostate and GU cancers, or is it someone who will do, a bunch of different cancers, whatever walks in?
Oh, I think he treats a variety of cancers.
Yeah, so you're not getting the care that I think is appropriate in this day and age.
I did discover something. Let's see if this means anything. On the the treatment area was number 1, PTV. Then it's pros, PROS space PROX capital SV. That's treatment area. Then the technique is defined as SBRT. Then it's capital letters VMAT,
Mhm.
capital IG. Then it goes through some letters and numbers. X06FFF, PTV volume 96.5% volume. I don't know what all that.
So that's interesting. It's saying you had a pretty big prostate.
Oh, it did. Okay. Oh, okay.
96 cc's.
Well, it said 96.5% volume. The CC's just said
Oh,
96.5%
okay.
volume.
Okay. So that doesn't really help much in terms
Okay.
of figuring this out.
Okay.
But and they never talk to you about doing ADT with the Gleason 4+3. So you're not getting the care you should.
It says he was treated with radiotherapy alone due to minimal GG4 and prior TIA.
Well, there is a risk with some of the medications. Certainly, the agonists are at greater risk, and Orgovix appears to be safer. Um, they should have at least talked to you about it because that is the standard for Gleason 4+3. Yes, there is a risk. I'm not sure with with a TIA whether there's an issue with doing that with
So,
using.
so I have a couple of things as I'm listening to this, Richard. Um, who provided you with this report?
This is the doctor's notes, Dr. Stephen Greco, and it's off of the Johns Hopkins website where you can view the doctor's notes.
Okay, so these are the doctor's notes at Johns Hopkins. And
Mm-hmm.
were you treated at Johns Hopkins through the VA, or did you go directly?
No, I went directly to Hopkins.
Okay. So I think you have every right to call Hopkins and tell them you want a conference with Greco and you want him to walk you through these notes.
Yeah, good point. Okay.
Okay, now that's where I would start. I mean, don't be asking us at AnCan or Dr. Mark or Dr. John or any of the other physicians here to help you understand them. These are your doctor's notes from the doctor who treated you, who you're paying or Medicare is paying. And if you don't understand what he did, you start with calling them and saying, I need to go through this with my doctor. I'd like to know what was said. If you don't have one of our t-shirts or sweatshirts, you need to go to our website and get
Richard
one.
Advocate. I remember that. Yes, I do.
All right, because what does it say on those there? Be your own
Be your
best
own
advocate.
advocate. Right.
Right. So don't ask us to be your advocate.
What?
Our job is to train you to be your own best advocate.
Right.
And we're doing that by saying to you, you have every right to go back to your doctor
Yes, you do.
and ask him, what the heck does this mean? It's gobbledygook to me. I understand it wasn't written for me, but I think there are things in here that maybe you didn't explain to me. And
Right.
I'd like
I'm
to
just
know.
bringing this up to see if I get enough raised eyebrows here. See, I am. Okay.
I mean, Dr. Mark, what do you say about that?
Well, I'm concerned about the PET scan, and even if the issue of a TIA would make it so you didn't want to use ADT, they need to have that discussion with you. You did not have informed consent. I can't imagine why they wouldn't do a PET scan in that situation. It just and there's something that in the story that doesn't make sense, and it may be that you don't have the whole story and I'm not hearing it right, or it may be that they're just not in line with this. We have one more person to get to here.
Okay. Thank
um,
you.
I know that Doug, you signed in late, we didn't get a chance to talk to you, and Joe, and Jose and Sherelle. We will be back in 2 weeks, and more than happy to get you guys into the group. But let's go to Stuart. We're on with you. You're up.
Uh-oh.
Stuart, we can't hear you. Sorry.
Make sure you got the right microphone selected on your settings.
Yeah, you're unmuted. You're unmuted, but now you're muted again. Paul, you had a hand up. Are you still wanted to say something?
Actually, I was just going to ask Richard what his decipher score was.
Call here. Let me see.
That might make some decision with the doctor not following
Yeah, I don't have that in front of me. I got
ADP.
trying to look here at the old Decipher score. I don't have that in my fingertips. Yeah, it's pretty high. I was high across the board and everything.
Oh
I
yeah, it
just
was high.
didn't
Yeah,
make notes.
yeah,
Yeah.
yeah. That will be one of the main determining factor beside the 4-3, of course, to whether you need ADP. That's what I was told.
All right. Thanks.
Okay, Sherelle, we'll give it one last try if you can get your audio going. And it doesn't look like that's working tonight. Sorry. Any last words from anybody here?
Hey, Mark, this is Causey. For the guys who can't get on, whose microphone doesn't seem to be working, I had this problem about 2 or 3 weeks ago, and I had to go to Geek Squad, and it was something that went wrong in the GoTo app. And so Geek Squad fixed it for me, but I was having that problem where my microphone wasn't working.
We have our own Geek Squad person in the group right now. I'm generally pretty techie on this and have a background in electronic engineering and everything, and have been doing computers forever, building networks and the like. And GoTo did not like me as well. So our expert is on here now. If I look carefully, it looks like it says AnCan-Rick by his video there.
Okay,
Um,
I am not the expert, but what I suggest to all of you, especially Sherelle, is that you call uh, GoTo, and I will give you momentarily. I will try to give you the telephone number for GoTo, and work with them because they are definitely equipped to go through why things aren't working. Okay, let me give you the number for GoTo, since some of you may not be even on the website but on the phone. It's 877 582 7011. 877 582 7011. And just tell them that it doesn't really matter what room you try to get into, that your audio couldn't be heard. I had my own issues, as you may have noticed, when I came in, but it was because my machine had defaulted me to a video channel that isn't effective, and I don't know why it decided to do that. So it was definitely me. But 877-582-7011 is the limit of my audio support, technical support.
And I'm going to remind people, if they have not yet done the survey, go to the top of the chat window and you will see the link for that. We would really appreciate you taking just 5 minutes, 10 minutes to go through that and
Please,
give us some feedback so that we can do the best job possible for those who stop in.
please. And there's one other thing too, which is probably tomorrow, hopefully tomorrow morning, you will see our annual AnCan appeal letter. We don't ask for money on a regular basis. We're not like a lot of the other groups that come to you. I won't name them, you know who they are, but every time you open your email, there is an ask from them. We don't do that deliberately. We do ask in December once a year. That ask will be coming out tomorrow morning, and we ask you to embrace your generous hearts and support us because we need it. We do a great job for you. We hope you think so, but we need you to show us that you agree. Right,
And
Dr. Mark?
I wanted to thank Causely and Boykin, who wasn't here tonight. They work assiduously when I forget to hit the recording to truncate this and get a video that we can upload for you to look through and share with other friends to get them to come on board. Cesar.
I have a hopefully quick question. If we download the app, is it the GoToConnect or GoToMeeting app on Mac?
Meeting.
Okay, thank you.
Okay, well, everybody have a good evening and be
Thanks,
well.
everyone. When are
We'll
we back? When are we back, Dr. Mark?
The 14 days from today, that would make it the 23rd.
Okay.
So you must have
23rd.
eggnog to get in the room. Your
Oh,
microphone
okay.
probably will not work without some eggnog or something to
Okay. Do you
celebrate.
need a Christmas tree and gifts around the bottom?
Oh, we got that. I have to be careful. I've got a 7-year-old who might push it over. We're having some issues. It's
Well,
been a
it's some
fun
issues.
holiday.
Yeah, well, you know, whether you've got a Hanukkah, whether you've got a Christmas tree up, you're all very welcome. And by the 23rd, we hope you will have considered your Christmas gift to AnCan. So, and please fill out the survey. We really need your help on that. Thank you.
Have a good night. Talk to you all later.
Good
Have a good
night.
night. Thanks.
Good
Bye.
night.
Thanks.